Hello everyone, this is Sajini K. Saji, MBT student in Musculoskeletal and Sports Physiotherapy from BCF College of Physiotherapy. I am here today to present the current progression of my research titled Effectiveness of Core Stability Training versus Pelvic Floor Muscle Training on Stress Urinary Incontinence in Postmenopausal Women in a Rural Community. So, stress urinary incontinence is involuntary leakage of urine during unexpected physical exertion, coughing, or sneezing. Ovarian cessation causes systemic drop in estrogen levels, triggering progressive urogenital tissue atrophy and laxity in the structural pelvic hammock. So, when this sudden intra-abdominal pressure spikes occurs, the weakened pelvic floor fails to support the bladder neck, allowing the bladder pressure to override maximum urethral closure pressure. Statement of the problem and research graph. Pelvic floor muscle training stands as a conventional conservative gold standard for stress urinary incontinence rehabilitation. The abdominal cavity functions as a synchronized pressure capsule. The transversus abdominis forms the structural walls, and the pelvic floor muscles form the base. Isolated pelvic floor muscle training completely overlooks the essential dynamic co-contraction and pressure distribution mechanics provided by deep core stabilization. So there is no direct comparative studies isolating core stability training against standalone pelvic floor muscle training remains sparse, particularly among rural cohorts. The need and clinical significance of the study. When we are looking the epidemiological prevalence, worldwide prevalence of urinary incontinence exceeds 62%, in which in Kerala, regional data confirms the postmenopausal prevalence of 26.47%, with the stress urinary incontinence being the leading subtype at 13.9%. So this stress urinary incontinence affect the quality of life, restricting physical, domestic, and social behaviors, leading to progressive psychological distress, anxiety, and social isolation. And postmenopausal women in rural communities face cultural stigma, minimal medical access, and a widespread misconception that incontinence is a normal and treatable aspect of aging. To validate a simple, equipment-free, cost-effective community exercise protocol to restore physical autonomy in undeserved rural landscape was the clinical purpose of the study. Research hypothesis and objectives. The primary aim is to compare the structural and clinical effectiveness of core stability training versus pelvic floor muscle training in mitigating stress urinary incontinence severity and improving quality of life. The null hypothesis states that core stability training is not significantly more effective than pelvic floor muscle training in reducing stress urinary incontinence, severity, and quality of life. Where the alternative hypothesis states that there will be statistically significant variance between the therapeutic outcomes where core stability training is significant than pelvic floor muscle training in reducing stress urinary incontinence severity, symptoms, and improving the quality of life. Methodology, the study design and the selection criteria. The study design is quasi-experimental comparative study using explicit pre-test and post-test design. Convenience sampling was done for 50 postmenopausal women across selected rural wards of Adirampuza and Maravanthurthu Grama Panchayats among Kottayam districts. Out of initial pool of 50 allocated postmenopausal women, 47 completed full study following 3 dropouts during the 8-week timeline. Inclusion criteria include postmenopausal women of 50 to 65 years of age and positive baseline score on the standardized questionnaire ICIQUA short form questionnaire showing mild to moderate stress urinary incontinence. And in the exclusion criteria, predominant urge or mixed incontinence, history of pelvic or abdominal surgery within 1 year, severe pelvic organ prolapse which is at the stage 3 or 4, severe osteoporosis or any neurological disorders affecting the bladder function, or people undergoing current hormonal therapy. The outcome measures used include incontinence severity tracking. We have used International Consultation on Incontinence Questionnaire, Urinary Incontinence short form. It evaluates leakage frequency, estimated fluid volume loss, and direct lifestyle impact. Score ranging from 0 to 21. For checking the neuromuscular contracture strength, we have used modified Oxford grading scale, where digital pelvic floor muscle assessment via manual vaginal palpation was done. Score ranging from 0 to 5. Then condition-specific quality of life was evaluated using King's Health Questionnaire. It is a multi-domain map tracking functional limitations, role constraints, sleep disruptions, and emotional wellness. The interventional protocol include both AMPs receive supervised therapeutic sessions scheduled 3 times per week for 8-week duration. Group A was core stability training and Group B was given pelvic floor muscle training. The progression was for 2 weeks, that is 4 progressions was given among the 8-week schedule. For Group A core stability training from week 1 to 2, first progression, first we have given foundational activation exercises, and the second stage from 3 to 4 intermediate spinal or pelvic stabilization exercises are given, and from progression 3 from week 5 to 6, dynamic kinetic chain loading was given, and from week 7 to 8, advanced abdominal stability exercises was given as per given in the slides. Then the next pelvic floor muscle training group, the Group B, same progression was 4 times given from weeks 1 to 2. Localization and fast twitch recruitment was given, mainly Kegel exercises and its modified exercises was given. Then week 3 to 4, we have given slow twitch endurance conditioning, and week 5 to 6 we have given advanced vertical endurance holds, and from week 7 to 8 functional integration and the NAC was given, where the anticipatory pelvic floor muscle contraction executed immediately prior to the real world mechanical stresses. Functional integration in the daily activities are given. So these are the interventions given for the 2 groups. Project milestones and current progression status. Completed milestones including institutional approvals, rural community screenings was done, and group allocations have been successfully executed. Baseline pretest profiling, the full 8-week structured exercise protocols for both active cohorts and post-test data compilation was finished. The current status is that the final outcome data metrics have been systematically formatted. Advanced inferential statistical computation, parametrics testing, and dropout adjustment using SPSS software are actively in progress. Thank you.